So you go sideways, what happens there? You get something called portosystemic collaterals. So all these other collateral vessels in that area then start enlarging, right? Because what does collaterals mean? Collaterals means that these vessels form and enlarge bigger than they normally do, right? So where do your esophageal varices and gastric varices come from? From this, the portal hypertension and causing these collaterals to form, right? Okay, what happens then?
And
I put it in parentheses.
that also causes your platelets to get
Because you get splenic sequestration because you're getting increased flow through the spleen. You're exactly right. So this leads to a decrease in the portal vascular resistance in those vessels, which leads to vasoactive substance release. And then you're going to get increased venous flow through these systemic vessels, okay? And we'll get to the vasoactive substances on this other side. I just want to stick with this part, okay? So what does that lead to? Something called hyperdynamic circulatory syndrome. And that is named by a cardiologist because if you've ever come up with any cardiology major trial, they have all these really catchy names for it because they want to feel special. It's true. It's amazing. So someone like, oh, that's hyperdynamic circulatory syndrome. Like, what does that mean?
Big word means fancy name feels fine.
Exactly. All this means is you have an increase in plasma volume. What's that going to lead to? An increase in your cardiac output. How many times have you seen when they come out of the OR after transplant, their cardiac outputs are like 10, 12, they're super high. Or you get an echo and they'll say their echo is 75, 80% on their EF. So they get an increase in cardiac output. You're going to have an increase in heart rate. They're very tachycardic. And then you're going to get a decrease in your SVR because of these vasodilators, which we'll get to in a minute, okay? So your SVR is down, they're very vasoplesic, because we got to name it something fancy. I didn't go to medical school to say that they're, hypertensive. I want to say that they're vasoplesic. And their math goes down, right? The article I read, I laughed at it, because it was like, their math is normal to low. I was like, normal, we don't say normal.
So what about the pulmonary pressures? Because I noticed that when they
Calm down. Who's teaching this lesson? You. Okay. Hold on. All right. So portal hypertension, the systemic stuff, the hyperdynamic circulatory system. Okay. Okay. We could talk about portal pulmonary, but it's not on my fancy diagram. So give me a minute. All right. Does everyone understand this side of? Okay, great. So let's go back over. So you've got portal hypertension. Again, we've got the portal resistance and portal flow. This leads to splanchnic vasodilation from this. So let's head this way for a second, okay? What happens here, the theories behind it, because there's no proven mechanism, but the theory behind this is because of all of this happening, you get release of vasodilators. What are they from? They're from cytokines and inflammatory cytokines release nitric oxide, okay? You guys know about nitric oxide. You use it as nitric in the vent, right? What does that cause? It causes vasodilation, correct? So these cytokines get released, your nitric oxide gets released, that leads to splanchnic vasodilation. What's splanchnic? What vessels am I talking about? Yes, the gastric vessels, right? So you get splanchnic, that's gastric, vasodilation. What does that do? That decreases your effective blood volume because you're vasodilating and you're going to lose all the blood volume in the vessels, right? Because they're dilated, they get more leaky. They're not as taut, strong. What word am I looking for? Constricted. Thank you. What am I looking for? Okay. So then, this is the part that Rachel had to help me clarify because I was looking through this and I was like, the diagram just says baroreceptors. I was like, what? But what happens is this activates the baroreceptors. And what are baroreceptors? Do y'all know?
Sensitive to pressure.
Yeah, they're sensors that sense pressure. Baro means pressure, right? So these get activated. What happens then? You get an increase in RAS. You know what that is? Renin-angiotensin system.
Okay.
Increase in the SNS, which is a fancy word for systemic nervous system. I was like SNS, like SNL. Then you get an increase in aldosterone. Okay, let's follow this there, and then we'll branch off there in a minute. When that happens, you're going to get an increase in sodium and fluid retention. I think we've seen that once or twice, right? What does that lead to? Ascites, pleural effusions, all the third spacing that you see. Then the increase in sodium and water retention feeds back here to the increase in plasma volume and makes your hyperdynamic circulatory syndrome worse. Make sense? Do y'all understand the middle part? See how easy this is?
It's a two-part.
Okay, so we're over here with RAS, SNS, aldosterone again. What does that lead to? Well, RAS mostly leads to renal vasoconstriction. So when the RAS system feeds back, the renal arteries constrict big time. So this leads to decreased renal blood flow. And what's that? Renal syndrome. Exactly. So that's what happens when your cirrhosis gets bad enough. All of this is happening, and there are some of these people that are not retrievable, so to speak, from their hepatorenal syndrome. Okay? Does that make sense?
Hyperdynamic state leads to decreased flow to the kidneys.
But it all starts here with the portal hypertension, right? Because your portal hypertension leads to this, and then you've got a suspected chemical release from the cytokines of the nitric oxide. So your starting points are really here physiologically, which leads to everything else that we see happening with the liver.
Yes. In a patient have portal hypertension with
Yes, like Chiari is if you get
compensated liver fat.
no, if you get sudden obstruction of the portal venous system, it's called Chiari. So we classically see it in pregnant people. They'll clot, and then they'll get hepatic congestion and portal hypertension, but they're not cirrhotic.
Can the patient be cirrhotic without portal hypertension?
Sure. Eventually they'll get portal
They'll get-
hypertension.
okay.
Right, you've seen the cirrhotics where they're just chilling with their cirrhosis and they don't have ascites and they don't have esophageal varices, they don't have any of this stuff.
So this is more towards like end stage,
Yes.
right? Okay.
I mean, I wouldn't talk to a group of ICU nurses about basic cirrhosis early on, like what's to talk about.
Yeah.
This is the problem we're dealing with.
Mhm.
So it's decompensated basically. Because
Yeah, it's
he's
just,
talking about
but it's
compensated.
physiology that just falls apart. Because there's a certain balance that you can achieve with all of this, and then at some point you're just not balancing anymore, and you're done.
Becomes a cascade.
Correct. Right.
Is the HRS never resolvable with an empty liver? Like they are always going to need.
So I would defer to my nephrology colleague there.
Hi.
Hi. But my understanding, and he'll correct me if I'm wrong, is that the vast majority of HRS will resolve with transplant. But if they've got underlying CKD to a certain degree, they'll need a combined liver kidney transplant because the HRS is on top of the CKD and they won't recover. And I think that's determined by a biopsy, right?
No,
No.
it's usually for liver. It's very hard to make biopsies because of all the coagulopathy. So,
Is it protein?
well, it's a combination. I think that the rules are so if you have for more than 30 days abnormal kidney function, you're considered to have CKD. So probably your kidney function will not get back to normal completely. But for actually getting a kidney transplant, your GFR needs to be less than 30 at the moment of. So you have those two components, you know.
So less than 30
At the moment of the
for greater than 30 days, essentially.
no, less than 60 for more than 3 months.
Ah, okay. Less than 60.
But then at the moment, but we can, if you have like 55, we're not gonna give you a transplant, you know. But at the moment of the, because it means that you have certain degree of CKD.
Right.
And I think those are and those criteria are made by UNOS, they're not like ours, it's like, yeah. So we have to have evidence of having decreased renal function for quite some time. And then there are,
Months prior.
but then you also look at things like proteinuria and things like that make indicate that there's kidney damage.
Because if you don't have, you can't really, I mean, do you ever see CKD? You can't see CKD without proteinuria to some degree, right?
You can see it a little bit, just decrease of GFR, yeah.
Right. But not
Yeah.
like,
Yeah. But we usually see, yeah, like 3 months with CKD or at least more than 90 days. And then less than, GFR less than, at the moment of transplant less than 30.